Okay. Welcome again, and thank you for joining today's SPHR Health and Risk Communication for Public Health Network webinar series. I'm Zhao Sun, the Research Fellow at University of Birmingham. In today's webinar, we'll explore the topic of explaining osteoarthritis well. What are the next steps for health communication research? And I'm very delighted to introduce our speaker, Professor Clare Jinks, who is a recognized expert in health service research. Her research focuses on the management of pain condition in primary care, with a specific focus on osteoarthritis. In today's webinar, she will highlight the osteoarthritis impairment discourse and outline research undertaken to support osteoarthritis self-management, including co-design of new innovations to help explain osteoarthritis well. Details of an international initiative to change the osteoarthritis narrative will be shared before discussing the potential next step for osteoarthritis public health communication research. Yeah, just a quick note of timing. Professor Jinks, you will have around 30 minutes for your talk, and I'll give you 2 minutes warning towards the end. After that, we will have a time for Q&A. Yeah. So with that, over to you, Professor Jinks. Thanks.
Thank you very much. I'll just share my screen. Hopefully I can get the slideshow up. Perfect. Can you hear me okay? Can you see the screen? Yeah, wonderful. Well, thank you for the opportunity to present this research to you today, to the Public Health Network, Communication Network. I'm Clare Jinks, I work at Keele University, and I've been involved in a project around developing a new explanation for osteoarthritis, and that the original studies was called PEP-OA, and the O of OA, you can see, is a speech bubble in our logo, and that kind of gives a hint that this project is all about how we talk about osteoarthritis, and the project was funded by Research for Patient Benefit NIHR scheme. So in the 30 minutes I've got, I'm going to give you a brief background to osteoarthritis as a condition. I'm going to tell you about the PEP-OA study and the findings and how we've developed new resources. I'll describe just some of the knowledge mobilisation activity that we did and some of the uptake that we've had from our new resources, just briefly allude to some of the impact that we've had, and then just outline early thoughts working with Marco about next steps for possible health communication research related to this topic, and be really interested to hear your thoughts on what we can do next. So osteoarthritis is a condition. It's a very common condition. It's the most common joint disorder in older adults, and recently there's been a Lancet review, Lancet Commission on osteoarthritis, and the Global Burden of Disease project highlighted really the scale of osteoarthritis globally. So in 2020, just under 6 million people globally suffered from OA, and that's just under 8% of the global population, and we've seen a real significant increase in the number of people with OA since 1990, and we're expecting, this to continue to rise with population demographics and increases in risk factors. And OA has a real significant impact on people's quality of life. It's the 7th ranked cause of years lived with disability for people aged 70 and over. And of course, then it has a really clear impact on economic burden. And this is more substantial in people who are living with disadvantage. They bear a significant proportion of the cost because they have higher rates of disability. And of course, then that leads to reduced opportunities, for example, for employment. So one of the most recent Global Burden of Disease papers, the references here, summarised their conclusion that the demand on health systems for care for people with osteoarthritis includes things like joint replacements, they're really highly effective for people at the later stages of the condition. But the demand on health systems is going to really increase, and it's going to lead to further inequity for individuals and countries who can't access healthcare. So more can be done and should be done to prevent people getting to that late stage. So a real sense around prevention for this condition. And we have a problem thinking about prevention because we do have really strong and pervasive problems in society with how we think and talk and write about this condition of osteoarthritis. So we know it's very common and it causes pain and impacts on daily life. It leads to things like loss of work, loss of social interaction, and it also has impacts for mental health and other comorbidities. And there's a general assumption that nothing can be done for osteoarthritis, and that there are very many myths exist related to this condition. And this has been described by Samantha Bunsley and her team as an impairment discourse. And this impairment discourse exists very pervasively across society, in different populations, in people who have pain and people who don't have pain, in people of different cultures and different backgrounds. And it also exists among healthcare professionals. And these are the three elements of how Sam Bunsley's described the impairment discourse. And I've got on a later slide the references that you can go away and have a look at these in more detail. But there are essentially three elements of the impairment discourse. So the first one is that the body is a machine, and that the body is made up of different parts, and these parts, like a machine, can break down. And so osteoarthritis is a breakdown of the musculoskeletal system, essentially. The second area is around the ravages of age. And in this part of the discourse, that the joints, like machines, can break down. They have a sell-by date, and when they break down and when they're used, they need replacing. And then the third element is around osteoarthritis being a natural state of being. And this really is around the inevitable decline of the condition. So as the body declines, it's inevitable, it's part of aging, it's something to be expected and something that we should put up with for as long as possible. So Sam talks about the need to shift from this impairment discourse into a more participatory discourse. And this figure just shows some of the examples of what's needed to do that shift between impairment and participation. What examples of impairment talk and participatory talk, and the link is in the references that I'll show soon. So this impairment discourse is, as I've mentioned, is widely pervasive in society. We can see it in different ways we consume media, for example. We see it in the news, we see it on the BBC website. This is a recent article. We see it in print media. We see it in other forms of consumption in society. On the top right-hand side of this screen, you'll see some examples of greeting cards. And I've got a big greeting card installation which shows how the impairment discourse is played out in this kind of context in society. We can also hear it and see it and watch it in TV, in shows, in adverts, in quiz shows, in news. It's really pervasive in society. We see it in research. We've seen it consistently in evidence from qualitative research, in systematic reviews of evidence synthesis, of experiences of people living with OA and their experiences of healthcare. And we see recently some attempts to try and influence perceptions through, for example, written information, animations, other sources of how we can share more participatory language. And there have been some recent studies that have shown how changing the way that we write and talk about osteoarthritis can influence illness perceptions about the condition. So there are some examples there of work done in Australia and in New Zealand. And here are Sam Bunsley's series of editorials and examples of how we can shift the way that we talk about osteoarthritis. And there are 5 tips there around adopting a whole person approach, avoiding these mechanical analogies, thinking about what people can do rather than what they can't do, having consistent messaging, and also focusing on coaching and not curing. So really helpful resources around this impairment discourse and shifting to a participation discourse. And why is this important? It links to NICE OA guidelines and management of osteoarthritis. The figure here shows information and support is key core treatments for osteoarthritis. We know that misconceptions negatively impact on potential uptake of self-management, things like exercise and weight management, and there are missed opportunities for healthcare outcomes. And we also know that we need to take account of health literacy when we're developing information, written information for patients. We know in the UK that over 7 million people read at or below the average age of a 9-year-old, so we have to take health literacy into account. So all of this led to our study to develop an osteoarthritis explanation with a purpose, that we could help people understand the condition and their future with it, know that it's possible to self-manage OA and how to do this, and believe that recommended treatment would work. So we had a study with 2 research questions. What should an OA explanation include to encourage patients to self-manage their condition? And how can we deliver explanations to encourage self-management? And we drew on behavioural theory in our study. So we looked at developing a framework using 2 theories: protection motivation theory, so how people evaluate, they appraise threats to understand priorities, how that can help them change behaviour. And we use Leventhal's common sense model. And I'll just show this very briefly. This is just how we pull together domains from our 2 theories, protection motivation theory and Leventhal's common sense model. And we use these 11 domains of the theories to develop content for our new explanation. So the theory gave us 11 domains of which we wanted to match content in our new explanation. We wanted each domain to have some content in our explanation. So in the research, we had a multi-stage research project and we had patient and public involvement throughout the study. We had a workshop with stakeholders to look at existing sources of information and to look at allocating existing information into these existing theoretical domains. And we asked the stakeholders to do a RAG rating, whether the existing explanations and informations that were in websites that, for example, GPs would use or that were available through charities, whether these statements and sentences met our explanation with an aim. Will it help people understand OA? Will it help them know that there's something they can do about OA and undertake self-management? So we had this RAG rating through the stakeholders. Then we had a nominal group, so we had a prioritisation task with patients with osteoarthritis to help us look at which of these sentences and explanations were priority ones that should go into a new explanation for osteoarthritis. We then moved on to a conjoint survey, so a preference-based survey, to see which of all of the sentences and statements were preferred by patients with osteoarthritis to help them self-manage. And then we moved to a co-design phase where we brought together all of the preferred statements into new resources that can be used. So this is just a graphic to show that we had in the conjoint survey, we had new sentences and statements that had been developed through the conjoint survey, through the stakeholder work, and we put them against existing old statements. And we asked the people in the survey, which of the 2 explanations would you find more useful and would encourage you to self-manage your osteoarthritis? And we mailed this to just under 2,000 people who were registered with 4 general practices. So just one slide of summary, just the highlights that we were aiming for between 300 and 400 responses, and we had 428 responses back, which was a 22% response. And we had for 10 of the 11 statements categories in our new explanation, the new co-design statements were preferred over the old statements. So we pulled together the preferred statements from the preferences of people responding to the survey into new resources that can be used. This just shows the text version of what and what the new explanation for osteoarthritis contains. So these are all the statements that were preferred by participants responding to the survey. But obviously this isn't very useful for clinical practice or for in conversations or consultations. So we co-designed a new animation and a new leaflet that can be used to help discuss osteoarthritis, whether in daily practice, in consultations, in conversations, in different settings. So you can scan the QR code and you can access the resources through the links on the slide. And we've had just over 11,000 views of the YouTube video, and the leaflet is now being used in some musculoskeletal services locally. And we used the FLESH reading level as a kind of health literacy check in the written content for the written leaflet. So just some examples of the work that we've done in disseminating the results of the study. We did regional training webinars with healthcare practitioners. We've done presentations to clinical networks, and we've also engaged with some of the main osteoarthritis charities to highlight the work and to feed into their work that they're doing around myth busting for osteoarthritis. We also responded to a call from ITN Business around, they were developing a programme around Let's Talk About Joint Health. And we responded to this, and we worked with Versus Arthritis to develop a short piece that could go into this film. I'm not sure how I'm doing for time. This has had really good social media dissemination, and through their business advertising campaign, you can see here the reach that the film had. How are we doing for time?
You're good for time. You've got a few minutes, about 8 to 10 minutes.
Oh, good. Okay, thank you. So I'll just play this as an example of the short clip that came from the ITN news campaign.
Here at Keele University, patients, researchers and healthcare professionals are working as one multidisciplinary team to provide straightforward answers to straightforward questions. What is osteoarthritis? What causes it? This animation and accompanying leaflet have been developed in conjunction with patients. The resources contain a new explanation about osteoarthritis called Osteoarthritis and You, There Are Things We Can Do.
Nice to watch. Easy to understand.
The resources are evidence-based, using results from Keele's research study PEP-OA. The research found out what people with osteoarthritis want and need to know to help self-manage their condition. They're also freely available for the public and NHS to download by scanning this QR code and following the link to the keele.health website. John's been involved since the start of the project and even has a starring role in the animation.
At the outset, we decided that the language that most people associate with osteoarthritis is quite tricky to understand. How do we go about making it easy for the public to understand more readily what's going on? So the idea was to gather together all the types of phrases that people associate with osteoarthritis, and then have a survey comparing what we thought was a better phraseology to what was already in the public domain.
The patient involvement group have helped us pull it all together. So they've helped us with the storyboard, they've helped us to kind of work out what the images should look like, the tone of the animation. These resources help healthcare professionals to deliver recommended care and clinical guidelines, because we know that the provision of good quality information is core treatment for osteoarthritis.
Okay, so we had the short clip that we had from the film. We also worked with some of the clinical networks and provided news articles and kind of professional news magazines and networks. And we've had requests to use the resources from over 200 different healthcare professionals in different services in the UK. The animations are now in some international training modules for upskilling healthcare professionals in communication skills. The letters, the links to the written information are embedded in patient letters, and we've got some general practices using the animation in their waiting room screen. So we're getting some uptake of the resources locally, nationally and internationally. And we've got some feedback on how useful they are. We've got a brief survey linked into the animation and the leaflet. You can see on it's that we've only small scale feedback at the moment. This is something that we're going to need to develop to get more evidence on how useful the resources are. But we're getting some indication that that they're useful for healthcare practitioners in their practice. We developed an international collaborative to change the osteoarthritis narrative, and the study was kind of like a driving force for doing this. And we've had a paper published on a call for global action. And we're using a candidacy framework to help think about the ways we need to change the osteoarthritis narrative. And you can see in the top right hand, in the top circle there, that public health campaigns are linked into our framework around how people identify osteoarthritis as something that they're eligible for care for. So we've been awarded a pump priming grant, and we've got 12 months worth of work to do some priority setting in local communities in 5 sites internationally to look at the framework and think about what priorities are from different communities. So we've co-designed new resources. We've got some rollout and uptake of the resources through knowledge mobilisation. We're generating impact, but we know that there's more to do. So we're thinking about what might the next steps be in terms of communication and how we can think about how we can influence changing the narrative. And one way that we're thinking about doing this potentially is through new research relating to media production. And this is just something that Marco and I have just explored initially about potential to investigate how media production influences public opinion on the condition of osteoarthritis. And there are a potential number of components that we could do within a programme of research related to what's the population level impact of, for example, mass media campaigns that kind of promote this more participatory narrative. How do people talk about OE on social media? That's an area that we haven't explored yet. And also thinking about what are the experiences and perceptions of journalists who write about osteoarthritis. So there's some potential work we can do relating to media production and kind of influencing broad public health, broad public opinions, general public opinions about osteoarthritis through a participatory narrative. And there may be other steps relating to implementation of osteoarthritis management programmes. Implementation so far has focused on things like core treatments related to pharmacological management, pain management, exercise and weight management, and there's been less focus on a gap in participatory narratives as part of that self-management approach. So we could do some work relating to the impact of these new training resources and communication modules on the uptake and implementation of self-management, and link that with our new international initiative. The screen is frozen. It's coming towards the end of the slides. Yep, so just, I think a final slide just to showcase the patient and public involvement that's been worked throughout the whole of our research around the narrative for osteoarthritis, right through from helping to identify the research question at the beginning. We had a co-applicant on our funding application. Patients helped us to design the research materials I've mentioned through the PEP-OA study. They've helped us to disseminate the results, helped us with the CONE international initiative, and helped us to devise that brief evaluation survey that's linked into the resources. So real co-design and patient and public involvement thread throughout the whole of the study. So just some final acknowledgements, but the study was funded through Research for Patient Benefit and West Midlands Applied Research Collaboration. An acknowledgement for the PEP-OA team and the people who have helped us deliver the project during the course of the study. Okay, thank you.
Thank you. Thank you so much. I found that's really helpful for my research. I also did research in using co-design and trying to understand the narrative and other things. Yeah. Thanks for Professor Jinks' presentation. If you have any questions, just popping into the Q&A session or in the chat box. And I will read them out as we go. Yeah. So any questions?
Anybody got any experiences of doing kind of mass media campaigns or anything? I'd be really interested to hear any experiences of kind of how we can develop the methods of evaluation for kind of next steps.
Actually, I'm currently developing one social media campaign, but just in process. Yeah, my research focuses on type 2 diabetes and diabetes stigma. So for my previous PhD study, I also investigate the diabetes narratives posted on social media platforms. And then currently, I'm trying to co-design the workshop with people living with diabetes, healthcare professionals, communication, marketing, and media expert to design one social media campaign and to know how do they think what works for them and how to evaluate the efficiency or the effectiveness of those campaign. Yes, so that's really helpful for my research to know what you've done and how do you organize the co-design workshops because I'm currently in the process of preparing and these co-design workshops, but that will be happen in online. So do you have any maybe recommendations or any ideas or experience to know how to maybe organize this co-design workshop online or?
Well, we were forced online because it was COVID time, so we had to go online. We had a patient and public involvement group, probably about 7 or 8 members who had been involved throughout the course of the study, and so we had a series of 3 virtual workshops actually. So we already had the content from the survey. We had all the results of the survey, which provided the building blocks for what went into the explanation. So we weren't starting from scratch in terms of the content for the explanation. So the first workshop, we just really discussed the results of the survey and kind of just looked at the exact wording of the prioritized preferred statements. And we got an initial sense of thinking about the storyboard for the animation and for the leaflet. So they gave us clear indicators of what they wanted and what they liked and didn't like. So they wanted a journey, they wanted a storyboard. The storyboard kind of came together with representing a journey for patients to be able to do things that were important to them. So they wanted a positive tone. They wanted it to be reflective of a journey of people being able to achieve things that they wanted. They didn't want, you can have the kind of the stick person animation. They wanted a cartoony type animation, but not wanting it to be humorous. So, they advised us on everything to do with the style, the tone, the content, the ethos, around the format, the tone of the resources. And so we, over the course of 3 virtual workshops, we kind of worked all that out, and then we went away and had to develop the animation, and then we came back and discussed the prototype of it, and then there were some more changes because there were some things in there that weren't quite right. So it was an iterative process. Workshops were, I think, about 3 hours with a break in the middle. So yeah, and we paid the public contributors for their time for attending as well. So yeah, initially we thought, how are we going to do this over Teams, but it worked okay actually. But we had to allow enough time.
Yeah, thanks. I saw one question on the chat box. So great talks, thanks. I'm wondering regarding to social media research you have planned. What social media platforms are you interested in looking at?
Yeah, I don't know yet. This is genuinely that we've just started to think about the possible work packages that might be important, and yeah, so social media, I see things, our animation is currently housed on YouTube, and you can see, you know, it's great, it's had over 11,000 views, but now you're starting to see there's adverts and things that are linked to it that I don't know how aligned they are with our participatory discourse. And so so there's definitely, you know, maybe it's X or Blue Sky, or there are other possible communities. There are osteoarthritis communities. There are yeah, there'll be probably multiple options in terms of social media opportunities. So again, really keen to hear from anybody here today that's got experience of doing that and can advise on you know, how that might work, what the benefits are of different platforms. Yeah, because I'm also aware of the kind of the methods. If I start looking at things now, I'm just going to be getting algorithms, and I'm going to be getting stuff pushed towards me. So yeah, lots of complicated aspects towards methodology as well, I think, in doing this type of research, which I haven't done before. So I've done analysis of newsprint paper in the highest circulating newspapers, but I've not done social media analysis. So yeah, really keen to learn from anybody that has.
Yeah, I wanted to make a comment. I'm the one that asked this question, and
Oh, I can't hear you very well. I'm sorry.
oh, is it better now?
Oh, that's better. Yes,
Yeah.
thank you.
Yeah, it's very interesting, I think, with social media, because now Twitter changed to X, and like there's no as academics we can't like download like data from the social media platform anymore for free, and it's very expensive now. So I think a lot of like academics are looking at like alternative ways to like use social media currently. But I also think content on social media is like moving from like written words to like videos, like TikTok and even like Instagram. More videos are getting pushed, which I think kind of like changes the way we analyze the data. And I'm not sure if there is like even ways to doing it nowadays. But I think also with your research, because if I understand correctly, like more elderly people are affected by it. So I think that also is something to consider when looking at social media, because older people are probably more likely to use like YouTube or traditional media sites rather than social media. But yeah, I am doing a little bit of analysis with like social media data, but like it uses like Twitter and like Reddit from like COVID, but we are mainly looking at like the sentiment. So I'm not sure what exactly like you want to look at, but yeah, it is quite complicated, and there are a lot of like platforms and different ways to do it, but I just thought it was an interesting point.
Yeah, thank you so much. Thank you. Yeah, I think the point about the videos, and yeah, TikTok is a world that you know, I don't inhabit very well at all, actually. So it's definitely going to be a learning curve. And yeah, thinking about ways of doing that kind of imagery analysis, I guess, and possible ways to do that, and storytelling, you know, there'll be possible methods, I guess, to kind of think about in relation to the different ways of, you know, reels and TikTok, you know, things. So yeah, definitely something to think about. And yeah, I think your point about age is really interesting one, because we know that people are getting diagnosed earlier with osteoarthritis. Like the epidemiology is telling us that people, particularly in deprived areas, are getting diagnosed with osteoarthritis earlier. So whereas the clinical diagnosis is 45 and over, we're seeing that shift now to, you know, to 5 years earlier. And in terms of prevention and thinking about primary prevention and conversations that maybe are a bit earlier. Thinking back to that first quote on the slide around, yeah, joint replacement is much towards the end scale, you know, and we need to kind of shift it more towards primary prevention in having more general public health awareness about the condition, and yeah, primary prevention and prevention of OA getting worse, so that it's in people who do have it, so they don't end up waiting for ages on a waiting list and then thinking there's nothing that can be done, and then, you know, just waiting for that breakdown, like in the impairment discourse, waiting for the body to break down, waiting for the knee joint to be broken and to be replaced, and not considering other things. So yeah, primary prevention, maybe it doesn't need to be so age specific, but yeah, I completely take your point about the target audience and how we'd have to consider that in amongst a more generalized campaign. Yeah, thank you, really helpful.
Thank you.
Yeah, I saw several other questions pop up. There's one more. How would self-assessment video look like? And so that people could try to know their condition of the bone health and at the same time get motivated to exercise to check their bone health at times.
How would self-assessment videos would look like? People could try to know their condition of the bone. Yes. So, yeah, can you explain the question a bit more? Thank you.
Is that okay to use the
So, Giles, I'm not sorry, I don't quite understand the question. How would self-assessment videos look like so that people could try to know their condition of the bone health at the same time get motivated to exercise? So is it thinking about how
I think he's dropped out of the meeting, so he dropped out and back in again, so I think he's having connection issues.
Yeah, I think it's an interesting discussion we've been having in the team about again, within COVID, we did have a work package in the original project to do some think aloud interviews. So where we would sit with people who were watching the video and have a discussion with them about their initial response to the explanation that's in there, and get feedback around what that meant to them. Was it meaningful? Would it influence their behaviour in terms of, for example, physical activity, one of the main core treatments for osteoarthritis. So we were trying to get some of that assessment throughout the project by doing this kind of real-time think aloud method. And unfortunately, we had to drop that work package during COVID. So I think it's something that we should really think about picking up again, so we can get a sense of how people might use the resources and do that assessment of what it means to them and how that might impact on their behaviour. So yeah, we've not quite got to the bottom of that yet, but something that we should probably think about doing. We need to get more funding to do it, but yeah, it's part of the plan.
Yeah, actually, I also have something to share about doing research on social media research. If we can just let you know how that goes, because my PhD research focuses on trying to decide which social media platform I will use to analyze the diabetes related narratives posted by those social media influencers. So the reason that helps me to decide using Twitter is from the researcher perspective, although I would like to join these online forums or the groups on Facebook, because I know that people in maybe elderly age group, they prefer to use that online, but that's hard to join actually, because there are several questions before you prefer to join that, and they have restrictions whether the first question is whether you are living with type 2 diabetes or type 1 diabetes. If I'm only the researcher, that maybe already ask you to drop off. Yeah, and for the social media like Instagram, maybe there's one action such as 24-hour stories, but that much relies on the visual image analysis. So no, not much text maybe people just post a picture and several keywords to explain that. And so that's the reason at the time when that happened in COVID, I can still use Twitter API to obtain the data. There's loads of information there. And for analyzing the data on Twitter, at that time I developed one online social network-based diabetes narrative exploration framework. So, because the narrative on Twitter is not the same in the text or in the news. So we can consider the tweets serves as the small stories, and then the themes of the stories can be considered as macro narrative, and then the set of the themes of the stories can be considered as the narrative. So on social media, it's a totally new method to analyze all those information. And also there's emoji and the links, whether you decided to include them inside. That's my personal research experience, and I'd like to share more if you are interested too.
Yeah, thank you. Yeah, no, I'd be really keen to hear, because all of that complexity is challenging, isn't it? It's and it's definitely a different way of thinking about, well, there's access to the data, then there's how you analyze the data, all sorts of complexity that's different to how I've worked before. So it would be great to chat more offline outside of this meeting, so you can share your insights. That would be great. Thank you.
I think we still have some time for more questions if anyone have some. Oh, there's one more. Thanks for the presentation. Could you please share any major challenges you encountered, specifically related to data completeness and consistency than in social media research? Any challenges?
I think that's one for you, I think, more than me, because I haven't actually done social media research yet. So maybe some of the things we were just discussing around barriers to access, and that the data comes in different formats, that it's not traditionally, I'm used to looking at written text and transcripts from interviews, and done some content analysis of written articles, newspaper articles, doing thematic analysis and framing analysis, but that's easy to do on a written text. So I think the consistency in social media is completely different, isn't it? It's the format of the data is different. The completeness, how do you know what's complete when it's different, it's in a different form. And consistency, I guess, with social media, because it adapts very quickly, doesn't it, to trends and patterns, and so I guess it's more changeable than traditional forms of using media, where it's more static, like a written newspaper article, or I don't know, just off the top of my head, some thoughts.
Yeah, and for my personal experience when analyzing the tweets, if people only retweet, there's no more words in their retweeting content, I will not include those in my analysis. But if they retweet this information and add more information on that, I'll consider that as the pieces of the stories. If many people joined collaboratively to tell one story together, whether there's highs and lows, whether there's controversy happened, kind of the long story on social media.
Oh yes, okay, yeah. And did you take what was your time frame? What was your time period for the data collection? It's a snapshot, and so
there's I based on 3 diabetes related major event. So maybe the Diabetes Day, the World Insulin Anniversary, and also the National Diabetes Awareness Week. So there's 3 separate.
So you had events, you based it around key events. Yeah.
I think maybe added these key events around those time, people are more actively to join those conversations.
Yeah. And do you know how much have you compared kind of like diabetes narrative content to any other, long-term condition content, or do you know of any comparative analysis between conditions?
No, I did not do that because my research focused on exploring the potential of social media influences in health
Influences,
communication research.
Yeah.
So I identified who these influencers are, whether they are organizations, the independent influencers, they are people living with those conditions or healthcare professionals, and then what's the information they present on social media, and then what's the implications, their narratives on their audiences.
Yeah.
This logic. Yeah, so I did not do some comparison analysis. Yeah, but I think might be interesting to compare the information posted online and the information posted on mass media to know is there the different conversation and the discussions around the topic of diabetes and other health conditions. Yeah. And any other questions? And for me, can I ask one more question regarding to your research? Do you found there's any difference among the different people in demographic groups for your research? For instance, whether their preference are different for the priority issues in their community for what they consider that maybe which is the most important thing for them. Is there any difference in different age group, education level?
Yeah, we had in our survey, we had, despite trying to target general practice sites that were of a range of deprivation, we had 97% of the survey responders identified as white British, and I think it was 8% who said that they had sometimes or often problems reading health information. So we had a single item health literacy screener in the questionnaire to try and unpick issues around health literacy. But we only had, say, about 8% of people who identified in that group of sometimes having problems or always having problems. So, and 66% of the population who responded were women. So it's something that we've not been able to unpick at the moment, but it's something that we want to explore with the small networking grant that I mentioned. So we're going to be going into different communities and looking at what their priorities are, so that we can try and look in a bit more granular detail about what's important to different communities and what's important to them, and then how we can build that narrative linked to what's important to different communities. So that's, I think, work that will be coming hopefully throughout this project, and we can report on that maybe next year.
Yeah, that's interesting. And from the bottom, asking people for their preference and build up this project, and then just go down again to know is there any difference the community's preference. Yeah, that's great. Interesting.
There's more work to do, definitely.
Yeah, and I'd love to hear more about that maybe after this webinar. So I found that's interesting. Yeah. And
I think if that's all the questions, we can say thank you. Don't think there's any more on the chat.
Yeah, let's see. Yeah, I think that's the questions for today. If you have any other questions, maybe contact later at.
Yeah, happy to people to get in touch. Yeah, no problem. Yeah, no problem at all. If anyone's got any further comments or questions or advice, because I'm new to mass media, social media research, definitely. But yeah, really keen to hear if anybody's got any thoughts.
Thank you very much, everyone.
Yeah.
Thank you.
Before we close today's session, I'd like to thank you. Yeah, thanks Professor Jinks once again. Yeah, for this thoughtful and engaging presentation. And thanks to everyone for joining today's session. And we also hope to see you in our next webinar, which will take place on Wednesday, 28th of May. The topic is virtual art in health communication. And Dr. Marik Palace will be the speaker to present on this topic. And please feel free to explore more and register where the link will share. Yeah, Amy have already helped us to share the link. And after that, we'll post this webinar online to our webinar series on YouTube channel. And welcome everyone to follow our network homepage to know more information about SPHR network for health and risk communication for public health. Yeah, I think that's all the information for today's webinar. Thanks for everyone. Thanks, Professor Jinks.